Good evening to everyone. Thank you all for coming tonight. We are excited to have this virtual CSA Voices session where we seek to explore Caribbean voices and bridge knowledge across borders. It gives me great pleasure to welcome you to today's session and to serve as chair and moderator for this evening's event. My name is Sherelle Carrington, and I'm a clinical social work faculty member in the Department of Behavioral Medicine and Psychiatry at the Rockefeller Neuroscience Institute at West Virginia University. Again, thank you all for being here. I know we're all very busy, so we really appreciate you taking the time to share this evening with us. I see some familiar faces, some people who I personally invited to attend this evening's meeting, and I am deeply grateful for your participation tonight and for everyone's participation and continued support of the Caribbean Studies Association and our CSA Voices initiative. The CSA Voices virtual sessions will be a series of virtual events designed to showcase the diverse research within the association. This evening, we are honored to have Twanna Hodge, PhD candidate from the University of Maryland, College Park, and Dr. Anthony Briggs, Research Assistant Professor, Department of Neurology, NYU Grossman School of Medicine, as our featured presenters. And the focus of this evening's presentations is cognitive and mental health in Black North American and Caribbean communities. So again, everyone, we look forward to your participation, engagement, thoughts, and questions this evening. And before we go any further, I would like to turn the meeting over to Dr. Anil Hall, who is the coordinator for CSA Voices. I had the pleasure of meeting Dr. Hall at the last CSA conference in St. Martin, and I really enjoyed listening to him speak about his research. So I invite you now to give your remarks, Dr. Hall. The floor is yours.
Thank you, Dr. Carrington. It is my pleasure to welcome you to another edition of CSA Voices. CSA Voices provides a dynamic space for dialogue, reflection, and exchange where scholars, students, artists, and practitioners from across the region and our diaspora come together to engage with critical issues shaping Caribbean life and thought. So through CSA Voices, we aim to amplify perspectives that are rooted in Caribbean experience while also connecting them to broader global conversations. Each session highlights the intellectual vibrancy and diversity that define our Caribbean. And we are so pleased that you can join us for this session today. As we continue to build momentum towards our next annual conference, I want to take this opportunity, just like Dr. Carrington, to share an important announcement that our next conference will be in Kingston, Jamaica, a rich city with culture, creativity, a space for learning, connection, and collaboration as we explore themes that speak to the past, present, and future of the Caribbean and its global intersection. So please stay tuned to our social media platforms, our websites, our mailing list for updates on abstract submission and registration details. We encourage all scholars, artists, activists, and community thinkers, both emerging and established, to share their work and join us in Kingston next June. So on behalf of the CSA Executive Council and the CSA Voices team, thank you for your continued engagement and support. We look forward to a thought-provoking discussion today and to seeing many of you in person in Jamaica next year. Welcome once again to CSA Voices, and let's continue to keep the Caribbean in conversation. Thank you very much.
Thank you, Dr. Hall. Okay. So to begin this evening's presentation, we will hear from Twanna Hodge, and I will introduce each speaker before they present. Twanna Hodge is a PhD candidate in the College of Information, and she's working on a graduate certificate in Latin American and Caribbean Studies at the University of Maryland, College Park. She holds a BA in Humanities from the University of the Virgin Islands and a Master's in Library and Information Science from the University of Washington. Her PhD research focuses on the role of culture and ethnic identity on English-speaking Black Caribbean immigrants' mental health information, behavior, and practices. She was an academic librarian for over 7 years and is one of the co-creators of the Black, Indigenous, and People of Color in Library and Information Science Mental Health Summit, which was created during the pandemic as a space for collective care in an authentic and care-centered manner to increase awareness of best practices for self-preservation and wellness tools. She is a 2013 American Library Association Spectrum Scholar and a 2022 to 2025 ALA Spectrum Doctoral Fellow. Twanna Hodge, thank you for presenting this evening on how mental health professionals provide care to Black Caribbean communities in 3 countries. Phenomenological study. Twanna Hodge, the floor is yours.
Right. Thank you all so much. It is an honor to be here and to be invited to be a part of this. And I had the pleasure of attending my first CSA conference in St. Martin earlier this year, and getting to know many amazing people. And I did a poster session. And so this research is on my integrative paper, which is kind of our qualifying paper comprehensive exams for the University of Maryland College of Information. And so I am going to share my screen. I hope everyone can see my screen. Okay.
Yes,
awesome.
we can see the screen. Thank you.
Thank you. Okay, so I am from the U.S. Virgin Islands, so St. Thomas. I'm born and raised. I have Caribbean parents from Dominica and Angola, so the Caribbean roots is very deep within me. But I decided to pivot from being an academic librarian to pursuing a PhD in information studies, and it wasn't until like the fall, like legitimately like the last month in my first semester that I came across the term mental health literacy that made me completely change what my research was going to be. And for me, mental health is such an important thing. It's still highly stigmatized despite the pandemic and the changes where, you know, there's been an increase in people diagnosed with depression and anxiety. Stigma and many different types of stigma is still part of the issue when it comes to help seeking and information seeking. And then for me, this research is understanding the historical and contemporary factors that contribute to the existing mental health systems. So thinking about like how colonialism is part of the creation of the Caribbean. And so in regards to the mental health system, thinking about psychology and psychiatry, and then also thinking about like how mental health care is currently provided to English-speaking Black Caribbean communities. And so even though Black Caribbean immigrants constitute almost half of the Black immigrants living in the US, there's not as much research out there around Black Caribbean immigrants, mental health literacy, help seeking, mental health utilization, et cetera. And a lot of the times, because when Black immigrants immigrate to the US, they go through the racialization process, where at times your Black identity is more salient than your ethnic identity. So ethnic erasure becomes part of what they undergo as well. And when I was doing my literature review for my integrative paper, and right now I am in my dissertation proposal stage, and also in the middle of my interview in my literature review stage, identifying that there are a number of people that look at Hispanic speaking individuals or Hispanic phone or Francophone, but not necessarily English speaking, looking at folks from English speaking communities. So these are the research questions that guided my research. So how do mental health professionals describe the experience of providing care to English speaking Black Caribbean immigrants in the US? How do mental health professionals describe the experience of providing care to English speaking Black Caribbean communities in the Caribbean? To what extent do the experiences and perspective of mental health professionals providing care to English-speaking Caribbean immigrants reflect the historical experiences and perspective describing colonial systems? And lastly, how do mental health professionals who work with Black Anglophone Caribbean communities describe mental health care? And so, of course, because I am a librarian, but also, when you learn how to become a researcher, diving into the literature is a very key thing. And being able to identify, is there a gap? Is there aspects where certain communities are not being, their experiences is not being explored? So there's a lack of ongoing population research that's on the Black immigrant populations. It's not until 2024 where there was a recent study that looked at the effects of colonialism and psychiatric care of Afro-Caribbean migrants. And then even the immigration health and immigration mental health, which is currently being challenged a lot in the US, there is still a need to focus on specific immigrant groups and not to believe that it's homogenous. And then also thinking about mental health literacy, which was coined in 1997 by German and other Australian researchers, and where mental health information seeking is an aspect of that, but it kind of lacks cultural responsiveness. So these were the theoretical frameworks. I know that I'm kind of speeding, but I want to make sure that I get through this, and so you can have time to ask me questions. And so the two theoretical frameworks that I used was critical race theory, and so acknowledging that race continues to be epidemic and normalized through a number of different systems and structures, and information marginalization, which is where certain groups have been pushed to the margin through different socio-technical processes, and then looking at the impact that the institution and community level have on these communities. And so the methodology that I chose was from qualitative research methodology of a critical phenomenology, which provides a way to examine and understand the lived experiences of those living in the margins, the critical view of subjectivity, and the rigors of phenomenology. And I acknowledge that I'm kind of an insider-outsider, second generation immigrant, but not first generation immigrant, being born and raised in the Caribbean, but also being born and raised in the US, in the US Virgin Islands, which is a colony, which is a US territory, essentially. So for my data collection, I have worked with a number of different wonderful organizations, from the Trinidad and Tobago Psychological Association, I believe, and then Jamaica Psychological Association, to help distribute my recruitment flyer. So between November 2024 to February 2025, I conducted 10 semi-structured interviews that was conducted via Zoom. Excuse me. After the interviews, interviewees received a $50 Visa gift card. They first had to submit a screening survey. I had to get IRB approval. There was IRB delays, as well as recruitment issues, and so that I had to do an amendment. That meant that for me, it pushed back me doing my research an extra semester, which was a-okay with me. And so after the screening survey, the data and the demographic survey, if they were eligible, then I interviewed them. So all in all, I have about 13 hours and 39 seconds of interview time. I have 4 interviews from mental health care providers from Jamaica, 3 interviews from those from Trinidad and Tobago, and 3 interviews from the US. And so for my integrated paper, 10 were transcribed and analyzed. So in regards to the participant demographics, most of the participants worked in multiple settings, which is not uncommon. So most people worked in private practice. A number of people also worked in community mental health centers or with a government agency. I did collect information of racial ethnic breakdown. So majority of my participants consider themselves Black or African American, Jamaican, and even they distilled down. And then for the gender makeup, 50% were cisgender female and 50% cisgender male. All right, so what are my findings? So using thematic analysis, 4 major phenomena emerge. So patient-facing care, professional engagement, professional responsibility, and professional perspectives on racism. So the patient-facing care describes the experiences mental health professionals have when providing care to their patients. Then professional engagement describes the actions and experiences they associate with being a professional. So it could be getting engaged with organizations such as like CSA, or APA, American Psychological Association, or the Association of Black Psychologists. And it could be being a committee member to helping write policy briefs, et cetera. So professional responsibility, so that is including the actions and experiences of becoming mental health professionals. So that could be getting associates, bachelor's, master's, PhD, residency, et cetera. Or depending on the place, attaining licensure or credentials, the necessary credentials. And then 4, professional perspectives on racism. So how racism is part of the different systems, being aware of how racism is incorporated in different systems and structures and the effect it has on their clients' mental health. And so these are some quotes that represents, at least one quote that represents each of the major phenomena. So mental health professional from Trinidad and Tobago, the cost of counseling range from $200 to, when I say dollars, I don't mean US dollars, Trinidad and Tobago dollars, a session, and I've heard that it goes all the way up to $1,500, with cost differencing based on counseling type. Professional engagement, a provider of over 25 years remarked, they came back to Jamaica to provide the service and give the skills that they had acquired in the US, and became director of mental health there. They were director of mental health for many, many years. They recently retired, and now they do consulting and psychiatry for different agencies. Professional responsibility. One of the participants who was from Jamaica talked about the specialized training psychiatrists had to go through. And then in terms of like nurses and others. And then lastly, a US mental health professional said, I think you have to zoom out and remember that the field of psychiatry and psychology has been a handmaiden of the status quo. Historically has been a tool of the oppressor. That's its lineage, And so being cognizant of the way that role, that racism, anti-Black racism, colonialism, and colonial trauma have. There were some limitations. If I had a magic wand, I think I would have more time, be able to have more money to be able to give in terms of incentives, because I do know a lot of mental health care providers, they go through a lot of training. And a lot of these interviews range from being 30 minutes to 90 minutes. And for anyone who's ever sought any kind of therapy, the cost can range anywhere from, if you have insurance, which was something that also came up in terms of there being public funding or not being public funding, or insurance being employer-based. If I had a magic wand, I would have unlimited funds to give to these providers and expand my study. But the methodological limitations was just the length of time to recruit, and kind of restricted the quality, quantity, and diversity of the data. Empirical limitations for phenomenology and thematic analysis, it's not necessarily meant to be generalizable, but it's meant to highlight this specific subset and analytical limitations. Just the extensive time required for hand coding. I did not use SPSS or anything like that. I printed out the interviews and I have the stack of them right here, and went through and coded them. So some challenges. It was my first time as a principal investigator, even though I've been doing research studies and part of different research studies. This is kind of near and dear to my heart. So it was really slightly terrifying, exhilarating and terrifying to be like the one that is like coming up with the idea and going all the way through the implementation, data collection, and analysis. The IRB approval time, recruitment delays, IRB amendment. And so some surprises, I think, for me was also the ongoing effects of colonial trauma, scientific racism, and ethnic Eurasian mental health care research. I learned about the term drapetomania, which was a term that was coined, I think, in the 18th century. That was basically said that enslaved Africans who wanted to be free was mentally ill. And so, and there was another term that I recently learned about, but it's in one of the many books or articles that I've read. And then also the fact that one of the questions I asked was about like formal education around learning about people of African descent in your program. And there is next to nothing that exists in formal education, whether it's associate, bachelor's, master's, doctoral. A lot of the times they had to go outside of their program to learn about people of African descent, specifically people of African descent from the Caribbean. And religion and spirituality, I don't think is much of a shocker, but to me, the role of religion and spirituality in mental health and health seeking and information seeking was very, very prominent. In conclusion, mental health systems must facilitate improvements to create a more mental health literate society, but also to create content that is for us, by us, and that takes into account culture and ethnic identity. And so I was able to do this research because of the Latin American Caribbean Studies Research Pop-Up Grant. And I am extremely grateful to all of my participants, my advisor, Dr. Amelia Ann Gibson, my integrative paper committee members, the doctoral committee for allowing me to have an extension, and all of those who have aided me every step of the way to this point. These are my selected references because my references is multiple pages long. And these are some resources and questions. And I will stop sharing right now. I know that was a lot of information in a very short time. But hopefully everyone has taken something from my presentation, and I'm looking forward to hearing from Dr. Briggs.
Thank you so much, Twanna Hodge. We really appreciate hearing about your research, focusing on mental health professionals' experiences of providing mental health care to English-speaking Black Caribbean communities in Trinidad and Tobago, Jamaica, and the United States. I appreciated your reflection on colonial systems in mental health care and offering your findings and perspectives on how mental health care is provided today. As your presentation pointed out, developing a transcultural and trauma-informed healthcare workforce is crucial in order to create tailored and culturally informed mental health services and resources that will help address the growing mental health needs of Black Caribbean. I am very interested in what my colleagues will have to say, comments, Dr. Gitel Rahill, Dr. Miriam Pataski, who are also social workers and have done a lot of research on mental illness, and also my colleagues, Dr. Joel Vogt and Dr. Pamela Sullivan, who are psychiatrists in the Department of Behavioral Medicine and Psychiatry. So I'll be very interested after we hear from Dr. Anthony Briggs and how we collaborate and connect these two presentations. So Twanna, thank you so much. We really appreciate the discussion. And with that, we will now continue our evening's presentation with Dr. Anthony Briggs. Dr. Anthony Briggs is a research assistant professor in the Department of Neurology at NYU Grossman School of Medicine. His research focuses on the intersection of cognitive and sleep health, aging, and the social determinants of health, with particular emphasis on understanding early onset cognitive decline, especially subjective cognitive decline, among African, Caribbean, and American populations. Dr. Briggs investigates how social, cultural, and behavioral factors shape risks and resilience for Alzheimer's disease and related dementias. His work also includes developing community-based recruitment and retention strategies for clinical and population health studies, advancing participation in cognitive and brain health screening, and promoting health equity through engagement and policy initiatives. He earned his PhD from the University of Toronto and completed postdoctoral training at NYU Grossman School of Medicine Center for Healthy Behavior and Change in the Department of Population Health. Dr. Anthony Briggs, thank you for presenting this evening on improving cognitive health through education, practice, and policy among Black men. Dr. Anthony Briggs,
Right.
thank you. Thank you.
Let me see if I'm gonna see if I can try to share my my presentation. Well, thank you for inviting me to present. It's been a while since I presented at the Caribbean Studies Association. But definitely appreciate the invite. I also appreciate Twanna Hodge's presentation and all the organizers that have putting this together. I realized that there were some what do you call it? Some questions that I needed to kind of respond to. I thought they were part of the discussion afterwards, but I think I'll just get into it. So, what inspired me to address some of these topics about cognition, health amongst Black men? Specifically, it's multifold. There's multiple reasons. The first one is that, which I will address in this presentation, is that I did my dissertation on the psychosocial risk factors of Black men who are precariously employed as second generation Black men, second generation Caribbean men who had at least one parent that was born in the Caribbean. And I wanted to understand some of the experiences as they were navigating the labor market. They were all precariously employed, working part-time. Didn't have very much, they didn't have education, unfortunately, formal educated, didn't have health insurance. They were in neighborhoods that were deemed, or quote unquote, viewed as disadvantaged neighborhoods. And so I wanted to understand some of the systematic inequalities that they experience as they transition from part-time or precarious employment into full-time employment. And I had additional questions within my dissertation, but of course, I didn't have either the time or the resources or the funding to ask those particular kinds of questions as they related to health or mental health, stress, anxiety in particular. Because I did, I did take a social determinants course at University of Toronto to kind of just help me engage in some of the literature. But it would have required me, if I had pursued it, it would have required me to do additional 2 or 3 years in a PhD, which I didn't want to do. So I decided to hold back on some of my ideas, but also kind of pursued it in different ways. So that's kind of one of the reasons what led me to this particular topic. The second reason was that that I had some so of course, I had my main interest was the issues and discrimination issues that Black men experience in Toronto, and using my own personal narratives and the things that I had to deal with growing up with a single parent who was born and raised in Grenada. And so this kind of inspired me to pursue this research. But in addition, I had some family members, unfortunately, specifically Black men, one who passed away prematurely, I would say, in his middle age, passed away from a brain aneurysm. This happened in 1991 when I was about, and I think in my 10, 11, 12, or one of those ages, without giving up my age. But, and then unfortunately, and then another a Black man that passed away during COVID, who was born and raised in Grenada. So my grandfather in 91, who was born and raised in Trinidad, Tobago, passed away in New York City. And then my uncle passed away during the COVID based off of a diabetic coma, unfortunately. And so while he was in retirement, he was just visiting. And unfortunately, went to sleep one night and was in a diabetic coma for about a year. I mean, not a year, sorry, a month and a half. And then eventually passed away, didn't wake up. But it forced me to ask a lot of different questions. With all these various different experiences, it forced me and inspired me to ask a lot of different questions about how do we think about and conceptualize um, society, societal pressures, society in terms of challenges, in terms of systemic inequality, in terms of the workforce, in terms of retirement, all these various questions that I had brewing. And so I needed a space to kind of explore some of these ideas. And so essentially that's what brought me to this particular topic and why I'm so kind of passionate, not kind of, but so passionate about this particular topic. So I'll get right into it because I know we don't have that much time. Title of my talk is Improving Cognitive Health Through Education, Practice, Policy Among Black Men. This presentation is rooted in my core statement in examining the links between psychosocial risk factors, dementia risk, mental health stress, anxiety, while promoting health coping strategies for Black men. So today we'll discuss or try to get through some learning objectives. What is dementia, physiological and neuropsychological health disparities in Black men, potential mechanism of disparities, brain health equitable community approaches in practice and policy. So dementia is a syndrome. Dementia is generally a term for loss of memory, language, problem solving, and other thinking abilities that interfere with the daily occupational activities. There are multiple causes of dementia, and Alzheimer's is just one of the most common cause of dementia. So there's frontal lobe. Dementia is a group of brain disorders caused by progressive damage to the frontal lobe or temporal lobes, leading to changes in behavior, personality, language, cognitive function. Vascular dementia is reduced blood flow to the brain, leading to damage in the brain tissue. This can be caused by stroke, resulting in impacting the memory, thinking, and reasoning. And Lewy body dementia is a progressive brain disorder characterized by the accumulation of abnormal protein deposits called Lewy bodies in the brain, interfering with the brain function, leading to cognitive motor and behavioral symptoms. Now, there are two toxic proteins that contribute to Alzheimer's disease. As we look at Alzheimer's disease specifically, there's amyloid plaques in the protein that builds and clump together to form plaques outside the cells in the brain, while the NFTs, abnormal accumulation of protein called tau, and collect inside the neurons of the brain. Now, this figure reflects the continuum of cognitive dysfunction risk from preclinical to clinical. Preclinical is really a subjective cognitive decline. It's basically when a patient or individual reports, self-reports on issues regarding memory, memory complaints. And then mild cognitive to AD dementia, mild and moderate and more advanced. It's basically these are assessed through neuropsychological assessments and objective. It's a really objective tool to measure some of these challenges, right? So Alzheimer's disease health disparities, there are currently more than 6 million Americans aged 65 plus living with Alzheimer's disease, a number that is expected to be more than double by 2050. While older Black African Americans are 2 times likely as non-Hispanic whites to have AD other dementia-related diseases, research has not yet identified the common cause of this disparity. While Black African Americans are about 2 times more likely than whites to have Alzheimer's and other dementias, they're only 34% more likely to have a diagnosis. Now, this is a study conducted by Lisa Barnes, who basically tried to examine the issues of segregation that impacted Black African Americans as they, and so what she did was she tested them for cognitive performance and realized, and what she found was that segregation those Black Americans that have experienced segregation are more likely to do poorly on cognitive tests as early as midlife. Now, this begs the question that if this is happening during segregation, what is also happening during migration and integration and assimilation? When you think about migration from the Caribbean to New York, Caribbean to Florida, Caribbean to Toronto, Montreal, whatever have you, what are some of these, begs these types of questions. What is happening during this transition? Is there, in terms of dealing with discrimination, racism, risk factors, and all these other things? Now, there's not much studies that's pushing this to understand cognitive, but this is kind of some of the questions that I kind of think about as I think about some of these studies. So correlates of subjective cognitive decline in Black men. So this is a cross-sectional study based off some surveys conducted amongst 117 Black men between the ages of 40, midlife, 40 and up. And we found that neighborhood problems, so basically men that reported on subjective cognitive complaints, men that complained about their memory or issues, symptoms of memory loss or challenges, were more likely to experience neighborhood problems, vandalism, litter, noise pollution, bodily symptoms, aches, pains, breathing difficulties, tiredness, length of residency, the time of which they were staying in those particular neighborhoods. Sleep difficulties was correlated with some of these challenges, right? Of course, there's some key historical points that contributed to the medical mistrust. So we think about some of these challenges with SCD, or subjective cognitive decline, or memory, or stress, or whatever have you. Some of these challenges and key historical points that have impacted how men may think, and some men may think, based off some of these studies that have contributed to basically medical mistrust. And we look at the syphilis studies, the non-consensual radiation, which I won't get deep into, but these are some particular studies that didn't have the best outcomes and very unethical in terms of helping and supporting Black men as they think about and go through and address their health issues. So when we think about medical trust again, the lack of trust in healthcare system, it provides medical treatments. And addressing mistrust allows for equitable healthcare outcomes and a cultural competent research. Historical events, systemic racism and discrimination and other everyday experiences influences medical mistrust in Black men, as I said before. This leads to decreased healthcare utilization, late stage diagnosis of diseases, and hesitancy in the clinical research participation. Black men experience higher rates of death disparities and poor health outcomes due to mistrust, right? When we look specifically in the US, the life expectancy for Black men have the lowest life expectancy at 72 years old, which is 4 years earlier than white men and women. 4 in 10 Black men aged or older have high blood pressure and rate 30% higher than white men. Black men are less likely to receive guidance, consistent care, and be included in research. Black men are more likely to receive misdiagnosis when expressing symptoms related to mood disorders or PTSD. Black men risk stroke. It's twice of that for Black men. And Black men tend to be diagnosed at a later stage of Alzheimer's disease, limiting the effectiveness of treatments that depend upon early intervention. When we think about Black men, sometimes we don't necessarily, depending on who you speak to, some think about Black men as caregivers and some don't. But the stats are there that says that according to the American Association of Retired Persons, 2020 report on caregiving in the United States, estimated 2.5 million Black men are family caregivers and are more likely to have lower incomes and be unmarried. Right? So this Black males, so this is the one of my publications from my dissertation, Getting a Foot in the Door, a Critical Anti-Racist Analysis of Underemployed Second Generation Caribbean Black Males. My methodology was phenomenology, qualitative phenomenology, as you can see. I did one-on-one interviews. I went into the communities and met the men where they were at in those neighborhoods. And we did one-on-one interviews, whether it was in the park, whether it was in a community center, whether it was in a cafe. It didn't really matter. I just had to meet them where they were at, given the fact that I wasn't funded. And so I just kind of build up a rapport with them, and then just kind of reached out to them. So what I found is that, of course, in my study, Black males are greater risk of systemic racism in the job market driven by depression, anxiety, stress, limited choices. There's really limited choices and employment opportunities. And in another studies that another publications that I have from my dissertation, I talked about how they support one another in these times. And now these things, this is obviously good in the sense that they're supporting each other, but it's also challenging in the sense that they also need additional support in terms of navigating the labor market and the educational, for their educational pursuits or whatever personal pursuits that they have. We could get into that later. So one of the hypotheses that I also think about when addressing some of these challenges, or when Black men experience some of these challenges within a lot of these studies, is that some scholars have indicated that these racial disparities, specifically Black men, experience early health deterioration as measured across biological indicators of repeated exposure and adaptation to stressors, racism, discrimination, contributing to weathering, contributing to the accelerated physical, mental, and cognitive dysfunction. Traumatic events related to racism have been unrelenting for Blacks. In good times, racism is a stressor, and in bad times, racism is a trauma. Another theoretical framework, which I haven't got a chance to incorporate, obviously, in none of my studies, but I think it's something to think about. So a lot of these studies I have noticed is that when we talk about particular Black men, like the one of the studies that I mentioned earlier, it was a cross-sectional study. And so basically you meet them, you ask them a bunch of questions, and so they're able to give you, their narratives, their personal experiences, which is great. It's amazing. And we need that type of work. What we also need is also a mixed methods approach where we're looking at Black men over the course of, whether it's 10 years, 20 years, or 30 years. Of course, we need funding and resources and whatever have you for those things. But it's also important to see over time how these men are impacted by systemic inequalities, social inequalities, discriminations, and racism, and how that has impacted their health over time. And I think that would make for a meaningful and powerful research project. Just some ideas to think about. Now, there's some potential modifiable risk factors. So increased risk, cardiovascular disease, diabetes, hypertension, blood pressure, bad nutrition, loneliness, depressive symptoms, Parkinson's, change in BMI, sense of smell, insufficient sleep, current smoker. In order to decrease the risk of cognitive dysfunction, one is to be employed, to participate in cognitive activity, whether that's puzzles, whether that's enrolling in a course, whether that's playing all fours, dominoes, whatever the case may be. Physical activity, mix of resistance and aerobic, because some people like to do one over the other, but you should really do both. Social activity, as I mentioned before, continue to do so, to participate in social networking. I think some of the challenges with some Black men and some studies have indicated that, where Black men are sometimes, when faced with particular challenges, they like to isolate themselves because of fear of not being seen as, and the societal expectations of them not being seen as, strong or powerful. There's a sense of pride, a sense of ego, whatever the case may be, or there's a sense of shame, particularly. So there's some things that we need to still encourage social networks and social activities so that these can be buffers against some of the health issues. Take omega-3 acids, Mediterranean diet, purpose, live a life of purpose and meaning, and get sufficient sleep. Sleep is very important in terms of if you get poor sleep, you're more at risk to get increased cognitive dysfunction. If you have cognitive dysfunction in terms of you experiencing memory loss over a long period of time, more likely you'll experience poor sleep. And so it kind of works in a bidirectional way or two-way street. Obviously, I strongly encourage healthy lifestyle behaviors to be a protective risk factors for healthy brain aging amongst men. This helps estimated 50 to 70%, and as a protective factor against type 2 diabetes, heart disease, obesity, depression, and tension, a loss of productivity, better cognition, and mortality. Now, social determinants of health. I don't know how much time. The U.S. Department of Health and Human Services, Healthy People, endorses SDOH as the main priority, focusing on healthcare disparities in neurological disease. SDOH are the conditions and environments where people reside, born and worship, work, and age that impact their health and well-being and quality of life. The 5 major SDOH domains is economic stability, education and access to quality, healthcare access, quality, neighborhood built environment, and social community contexts. And so these are some of the health equity approaches for Black men and brain health. The first one is the implementation of brain literacy programs or brain cognitive literacy programs for all ages, from early screening and treatment for brain health disorders starting at preschool, elementary schools, high schools, and university. Awareness and cognitive health access for ethnic and racial groups could be achieved through the creation of multilingual brain health centers in vulnerable communities. Culturally tailored behavioral cognitive health interventions may increase adherence to physicians' recommendations among racial and ethnic minorities. Training and programs across all educational levels, from high school to university, and public health policies to address and reduce the burden of environmental, noise, light, exposure that are underpinning the cognitive health among racial and ethnic groups are strongly encouraged. Now, the takeaways for this presentation, there are many causes of cognitive health, dementia, and everyone is at risk. However, health disparities and psychosocial risk factors increases these risks in Blacks, especially Black men. The life expectancy of Black men have the lowest expectancy at 72 years old, which is younger than white men. Black men experience higher rates of death disparities and poor health outcomes due to this medical mistrust, and the decreased dementia risk comprises of multiple solutions: cognitive health, social activity, physical activity, good nutrition, living a meaningful life. And the future efforts should focus on community outreach, culturally tailored approaches that addresses the barriers to cognitive health, using mixed methods, qualitative approaches to addressing this particular problem. And I'm not too sure, but yeah, that's the end of my presentation. I thank you for everyone that's listening and on this call.
Thank you so much. Thank you so much, Dr. Anthony Briggs.
You're welcome.
Your presentation has highlighted the chronic exposure to stresses that Black men experience, like racism and discrimination, anxiety, depression, and stress, particularly within the workforce. You shared that Black men are at an increased vulnerability to cognitive decline due to biological, physiological, and psychological changes, and that the challenges that Black men face are often compounded by limited access to culturally responsive mental health care, persistent stigma surrounding mental health discussions, and structural barriers that hinder effective prevention and early intervention. Thank you so much for your presentation. Yes. So I have several questions. However, because our time is limited, and I would like to give an opportunity to our guests to ask questions. And I see a question in the chat. Okay, so we have, how do we sing Kill Alpha's song in a strange land using the oppressor's tool to heal us? That was a question from Shiva. And Dr. Rahill, I'm going to ask if you could comment on your text here. The main purpose of racism is distraction. From your research, it appears that the distraction is also from self-care and from thoughts and activities that can lead to flourishing. And if we consider that late adulthood phase of the life cycle, your subjects are navigating the psychosocial conflicts of integrity versus despair. This is very important work. Would you mind expanding on that, please, Dr. Rahill?
Sure. First of all, thank you, Dr. Carrington. You're doing a phenomenal job. And thank you to both presenters. I really enjoyed your presentation. A little bit of feedback for the first presenter. I know how hard qualitative data analysis can be. You don't have to use the whole bulk of printed transcripts. You can use something like Atlas TI. It gives you the opportunity to put all of the transcripts in one place, and you can analyze both within and across the transcripts. Holler at me and I'll be able to give you some feedback on that more directly. The second presenter, I'm sorry, my memory as I'm getting older. I just feel like in that late phase of adulthood, when people, you said the life expectancy for Black men is like 73 years old. When we're navigating this integrity versus despair and we're struggling with cognitive problems in addition to the lifelong burden of trauma that comes from being a Black man in society today, wherever you are. So I just feel like a while ago, I was at a place waiting for a friend to get a haircut. And one of the barbers was talking to a friend of his, and he kept saying, "What about me? What about me?" You know, and I just felt that. And I've always felt that there should be more research on experiences of Black men, both biologically, psychologically, and all these other ways, spiritually. And so your research elicited a very visceral response in me. I think it's really important stuff. And if the purpose of racism, discrimination, and all this other stigma is to cause distraction, then the ultimate distraction is from oneself, caring for oneself, and doing anything. We know that emotions can inhibit cognitions, right? We see that in neurocognitive disorders beginning from childhood across the life cycle. I'm going to stop yapping now, but this really provoked and evoked stuff in me. And I just congratulate you both on your important work.
Thank you so much. Thank you so much, Dr. Rahill, for your informed comments. I know you've done a lot of research in these areas as well, and I'm so grateful for your presence here today and for your comments to both presenters. Thank you for your support.
Dr. Carrington.
Yes, Dr. Pamela Sullivan, thank you for being here.
You're welcome. I'm sharing the screen with my husband, Joel, as you know.
Thank you, Dr. Vogt. Thank you, Dr. Vogt.
Nearby with our puppy. Sorry.
Thank you for being here. These are two psychiatrists from my department. Please, we welcome your comments.
Thank you. Yes, I had a question, or actually just, I wanted to bring up just a brief topic with Dr. Briggs with the second presentation. Very excellent, very detailed, covered many aspects. One aspect, though, I've had of interest and wondered if there might be some comments under the potentially modifiable negative risk factors would be both alcohol abuse and substance abuse, maybe even in general, and in particular, since alcohol we know can contribute to dementia, even specifically as a cause of certain dementias. So I wondered if you might have any comments on that as a modifiable risk factor in Black men.
Thank you so much for your comments and questions, Dr. Sullivan.
Yeah, so it's a great question, because it definitely, for me, it evokes a lot of different insights. One in particular, a couple insights, because one personally, in terms of, I see how some of my close, relatives, family members, or friends, or whatever have you, men, Black men, how they cope with particular issues of discrimination, racism, inequality, and whatever have you. And for some, they partake in alcohol, and others, marijuana. And so that has been challenging to engage in with them specifically, because I think sometimes on one end they think that they're coping well, and they're getting, medicated, so to speak, quote unquote, medicated. And on the other end, it's not necessarily helping them. And so I think that's an area that needs to be explored more. I'm aware of some scholars tapping into that space. I think in terms of the long-term impacts of it, one is relatively new in terms of it, how it's being studied when it comes to dementia risk, but depending on which scholars you speak to, they'll say definitely it has definitely some long-term effects, particularly in mood disorders, and attention, and ambition, although those who partake in it may say something different. But in terms of, they feel very ambitious, but that's not necessarily the case. And some suffer from psychosis in some instances. And so I think it just needs to be explored a lot more and more deeper. So that's where where I'm coming from on that particular topic.
Thank you.
Yeah, hi, I'm Joel Vogt. I'm her lesser half. I'm also a psychiatrist, and I was curious, in the mainland U.S., psychiatric medicine does a very poor job of doing anything for preventive health. We fix things after they're already broken. And you did a very good job of listing some of the modifiable risk factors in that. I guess my question is what your thoughts are on the best forum to disseminate that information to people, especially to minority patients, in that it doesn't seem like institutional medicine does a very good job of disseminating that information. Whether there are social groups, churches, community centers, where who are the trusted people, and where are the places people can gather to kind of get some of this information.
Yeah, so I know that there's a lot of studies on how to approach it from a non-traditional, and I guess a not a clinical way, and that's some aspects. I'm not sure if my colleague friend is on here as well. Warren Clark, he does a lot of work on barbershops, and so that's one particular avenue that you can kind of look into, and not just use it as a space to have critical dialogue, but I use it as a space to sometimes, in some cases, address some of these issues. So if you know that you're interested in doing stuff on, for example, mental health, and you want to know the issues in particularly related to depression, anxiety, and so forth, then you can also meet them and, you can still use clinical surveys and have them ask, respond to some of those particular questions. You could do it that way. Or you could do it another way where you say, "Oh, I want to address maybe blood pressure or hypertension or whatever the case may be," and still go in that avenue as well. Or you don't want to use barbershops. You can use churches. You can use wherever you feel that there's a good percentage of Black men, sports related issues, rec centers, whatever the case may be, where they feel comfortable in having these types of conversations. And so you really have to, one, build a rapport and meet them where they're at, and then see it from there. Because I think they all could be beneficial. You just have to think outside of the non-traditional or the traditional spaces.
Thank you.
Thank you. Yes, thank you so much for your question, Dr. Vogt, and for your response, Dr. Briggs. I appreciate it. Thank you. I wanted to allow anyone else, give anyone else the opportunity to ask any questions or to have any other comments. I see Twanna. She said it is generational as well as digital literacy and information literacy skills play a role. Would you like to say anything further about that, Twanna?
So I am a millennial. I embrace that. And so one of the things I've recognized is that Instagram and Facebook is the ways that a lot of people, and WhatsApp too, is a way that a lot of information is disseminated, particularly during times of crises, like thinking about the COVID-19 pandemic, but also thinking about the role that information literacy plays, so the ability to know when you need information and being able to find that information. And putting on my librarian hat for a second, thinking about a lot of the censorship, book bannings, a lot of, currently right now in the US, we're dealing with the government shutdown. So that means a lot of information is not being collected or updated in a number of different ways. And so people's ability to be able to look for authoritative information, be able to assess is it credible or not, and even thinking about, digital literacy, people's ability to use the internet and any internet-enabled devices as well becomes a role. Like, even though I do have an iPhone, I probably can only I know how to use about like 36.9% of it, and so there's a lot of things that goes into information dissemination, but even thinking about like the reading comprehension levels of how a lot of things that are patient education materials might be a little too complicated, even for somebody who has a bachelor's or master's degree at times. And so I'm also a TA for an undergrad class that talks a lot about digital literacy and information literacy and misinformation and disinformation and fake news and things of that nature. So and it's very political too, as well as we consider thinking about medical information and then thinking about is it accessible to somebody who has no affiliation to any organization in university?
Thank you so much, Twanna, for your comments. Much appreciated. Is there anyone else who would like to share any comments or ask any questions of our presenters? Shaiva, I see you have made some comments in the chat. Would you like to expound on anything?
Actually, I came in to hear the scholars and to hear what the scholars had to say. And I appreciate the information and the research. What I question is with the fact that getting help is such a challenge for most people, especially us people. I really question what percentage of people are really being looked at, and just the perspective. Okay, so how narrow is the perspective of this research? Getting help, even myself as a holistic psychologist, it is so hard to get really good help, mental help, psychological help in the community. It's a challenge. So I really question the efficacy of the research. And I ask, what is missing? Because see, we're looking at the oppressor's system. Could we look at ourselves outside of the oppressor system and kind of come up with what we think might be needed outside of the oppressor system, almost like starting fresh. So I look to the millennials a lot these days because that's our future. So I'd like to know more about where they would like to go. And I do know that COVID has put even more pressure on our situation. But I just like to implore that we jump out of the oppressor system and just try to take a clean look for a moment. And that's my comment. And I really appreciate this because sometimes I feel like I am alone out there seeking integrative and alternative measures. So I appreciate you. Thank you so much.
Thank you so much, Shiva Merritt. I am so grateful for your comments. It's so important that we feel heard and that we give a voice to the people who are here, to the people that we are doing research on. And so I'm grateful. I am so grateful that you felt comfortable to share your concerns and your questions. Thank you. And I would like to give either Anthony Briggs or Twanna Hodge just a few minutes since our time is short to respond, please. Whoever feels they would like to answer.
So I will jump in, and I am going to add this resource to the chat box. So, Shiva, to your point about thinking about, outside of these things, because we're very much, mired in these colonial systems, and there was a lot of talk about what is decolonization, having a decolonized mindset, eradicating anti-Black racism, and it seems that we have kind of gone a 180 in certain regards to that. But Dr. Ruhan Benjamin's book, I recently finished reading Imagination and Manifesto. I think part of that is imagining something completely different than what we are currently undergoing. And the thing is that a lot of times, and to Miriam's question, thinking about the day-to-day, the minute-to-minute, where a lot of these systems and structures are in place to prevent us from being able to imagine something different and then to put into place something different. Because it is hard to think about, looking for a therapist, paying $30 or $50 or $75 copay, or maybe $250 when you have to decide about, what you're going to eat, or paying your light bill, or deciding if you're a caretaker, all of these things. But part of it is taking that time. And I love Trisha Hershey's Rest is Resistance, Not Ministry. about like not grinding ourselves into dust, understanding that we live in a capitalistic system and we still have to go to jobs and pay our bills, but also rethinking the fact that like this is not what our ancestors want. This is not, we're not meant to just survive instead of thriving, instead of having an imagination. So I think for me, a lot of it is pushing back against the, you know, we need to be struggling, we need to be surviving, we need to be grinding ourselves away, and really thinking about reimagining, which is also seen like a privilege. But there's something that Audre Lorde had said that wrote that poetry is not a luxury. And so really thinking about like the things that gives us life instead of the things that take life away from us.
Thank you, Twanna. I really appreciate your comments. Yes, beautiful. And I thank you also because you referred to Dr. Miriam Petoskey's comment where she said, a big barrier to healthcare is when you're surviving day to day, you're not going to think about your old age. You may not even expect to get there. How do we change this present day orientation? So I thank you even, you know, in addressing and responding to her comment in your comments. Thank you. And I don't know if Anthony Briggs, would you have any final comments either to what Dr. Petoskey just said or to what Shiva just said? And then I will wrap up after that.
Yeah, so so in terms of, I think there's a couple points I want to make before I make my final contribution. The first point is that we do not forget, I mean, I think we, just to kind of reiterate, just do not forget who we are once, you know, when we're trying to address our health issues, maintain this purpose life. Don't forget, like if you had a hobby or if you had a talent or if you had something that kind of kept you going from when you were 20 to 60 years old, you don't forget that. You continue to maintain that because that's what's going to keep you going. I think in terms of dementia, we like to think about dementia in terms of losing memory, but memory is actually the last thing to go. There's usually something in terms of mobility and other things, factors that play into dementia or memory loss. And so if you maintain and participate in these particular things that you actually enjoy, then these are protective factors, whether that's engaging with family, friends, participating in whether activity. And I was just going to use poetry because I think some men may not write journals, but they might find other avenues to kind of engage in some of these things to help them. So it's one page. I might go a little bit over. I apologize, but Anil said I could go over.
Well, then you go right ahead because Neil is in charge.
So I wrote this a while back, but anyway, it goes. It's entitled Scholarly Poetry. I wasn't ready to be a scholar with inbuilt tenacity amongst the wolves in sheep's clothing, never concerned with ends, but more focused on empowering vulnerable individuals where hope and faith is sometimes dismal. And certain situations are deemed as a lost cause, but knowing that any cause is worth fighting for when injustice is involved. You got to be ready to weather the storm, where your remedies have to be Jurassic in a park full of problems going beyond parameters, not afraid to get your hands a little dirty, standing your ground in controversy. My third eye is the hidden gem, offering a new perspective that is forward-thinking, refusing to be stagnated in a world that reproduces robotic clones, never questioning. You know where my heart is, only concerned when you see me or people like me as a threat to your progress, resulting in anxiety that may cause stress. However, don't need to stress because I'm more than meets the eye. The plot thickens when you get to meet the core of my being, constantly misunderstood because I don't share the same interests or not easily amused by the racism or any other isms. Sugar-coated with phrases such as that person had good intentions, but I should excuse the ignorance. That is the problem. How many Blacks are misunderstood, wrongfully accused because of these toxic false definitions? If you just took the time to speak to them, you might begin to see that they may even have more logic than you. Using analytical skills to combat the demon of poverty, limited food supply, absent from classes, balancing the school and work life, trying to keep their heads above the brinks of backlash and judgments from the privileged few who can never even fathom walking a mile in their shoes. Contorted realities, or what a catastrophe. Beyond virtual reality, as you have no clue as they carry the world on their shoulders, searching for purpose and the meaning of life to society. That where some sees the worst in them as millions watch on ABC, PBS, and CNN News, as some investigators still have no clue When will we take the time to see the best in our future kings and queens? Allow the best from within. Don't keep the lion in the cage. Let them erected tall on the stage like a phallic symbol while the community is left in shambles and some never even given a chance to work because of their postal codes and neighborhoods. As the justice become the credential that is needed to make it in the society, part of the metrocratic illness, camouflage, and democratic optical illusions, saying everyone can make it, but only few do, as those brothers and sisters in the streets are the true scholars, ambitious, hungry, determined, and thinkers of the next generations. Make sure you open the channels of your social chain, take a page from their thesis on life, let your mind be blown, because I'm just here to make sure the seed is sown so that these young blood stories can be told and owned.
Wow. And you see all the hearts you're getting.
Ashe,
Thank you.
ashe, ashe, and akira.
Mhm.
Thank you.
Thank you.
Thank you so much for sharing your poem. It takes a lot of courage to be vulnerable like that. And you speak for many, many people. So thank you. Thank you so much, Dr. Briggs, for sharing your poem with us.
You're welcome. Thank you.
You're welcome. I would like to acknowledge Dr. O'Neill Hall as the coordinator for the CSA Voices session. And I would like to thank Twanna Hodge and Dr. Anthony Briggs for their presentations. They're excellent presentations today. They have left us with a lot of food for thought. Both presentations highlighted that Black Caribbean communities and African American communities here in the United States face unique challenges, including racism and discrimination. And experiencing racial disparities impact cognitive and mental health outcomes. Both presentations emphasize the importance of education and clinical practice as interconnected strategies to improve cognitive and mental health outcomes in Black Caribbean communities. Through health initiatives, community engagement, and equitable policy development, we can enhance awareness and reduce stigma. And by addressing social determinants of health and supporting culturally relevant, sustainable mental health interventions, we can foster resilience and promote long-term cognitive and emotional well-being among Black Caribbean communities. I would like to thank you all for your participation, engagement, thoughts, and questions this evening. Our goal is to build on the mission of the Caribbean Studies Association, which is to foster dialogue, collaboration, scholarship, and community across the Caribbean and its diaspora. We look forward to your participation and engagement at future CSA Voices sessions, and of course, at the CSA conference in Jamaica next year. Thank you for your time and your presence today. We are honored by your presence. Thank you. Have a wonderful evening. Bye-bye.
Bye, everyone. Thank you, Dr.
Okay.
Carrington and presenters. Bye.
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 Dr.
Bye.